Hi, everyone. Welcome to the University of South Carolina Big Data Health Science Center seminar. So this is one of the 3 showcases for our Big Data Health Sciences pilot project programs. So in 2020, the Big Data Health Science Center launched the pilot project programs. So we were fortunate to have many applications across the campus, and we fund 12 high quality pilot projects. So we ask the PIs of this project to give a introduction, a presentation on their study protocols. So this is the one and also the last of the 3 showcases. So today we have 3 speakers. So the first is Dr. Banky Alatosi, Assistant Professor and the Director of MHA Program at Arnold School of Public Health, Department of Health Service Policy and Management. We also have Dr. Ronda Hughes from College of Nursing. Ronda is the Director of the Center for Nursing Leadership and Associate Professor. She is also the Director for the Master of Nursing Informatics program. We also have Dr. Swann Adams from College of Nursing, but she also has a joint appointment with Arnold School of Public Health. So she's the professor at the College of Nursing and also with the Arnold School of Public Health Epidemiology and the Biostatistics Department. So we look forward to hear their presentation. So before I give time to the speakers, I just want to let audience know for more information on the pilot project program. We are in the process of reviewing the current application, but for more information for the one we fund in 2020 or for any future activities, or for other research training activity offered by the Big Data Health Sciences Center, please visit our website at bigdata.sc.edu. We also have a statewide network in the form of a list server. So we use that as a communication platform for people who are interested in the big data health science research and the training across the state. So if you have not joined us, please send your email to Miranda so we can invite you to participate. So that's all I want to say. So then thanks to the 3 presenters for their presentation ahead of time. So now let's start with Dr. Banky Alatosi.
Thank you so much. I'll go ahead and share my screen. All right, good morning, everyone. Just gonna talk about our pilot project, which is ongoing, which is focused on the power of big data for predicting future sexually transmitted diseases among people living with HIV. I'm working on this project with Dr. Jaja Zhang. And what we're gonna have today is an outline of our journey, which is we'll go through an introduction, talk about the background and significance, look at our specific aims, our strategy, future plans, and questions will actually come at the end of everyone else's presentation. So please make notes of questions that you might have for us. So most people are not aware of this or paying attention to this. Up to 2015, 2016, we were going in the right direction with STDs and the rates were falling. But since 2015, we've kind of changed. At 2018, we had the highest number of STDs ever reported to the CDC. And we thought that was a one-off. But unfortunately, the most recent surveillance report proves that it is not. And so as 2019, which is our most recent data, we are continuing to go in the wrong direction with continued increases in sexually transmitted diseases across the nation. And all of this increase is actually occurrences, like I mentioned, 2015 to 2019. And we think just by what has happened in 2020 with COVID, and that the pattern is going to hold for the same year. So we have a problem, right? Because sexually transmitted diseases by their very nature are transmitted sexually. And that has implications for people living with HIV, whether they are aware they're infected with HIV or unaware that they're infected with HIV. The other problem we see with this is there's an unequal burden for sexually transmitted diseases across the nation. So using the 2019 most recent surveillance report, it's 5 to 8 times higher for Blacks, and we'll keep that in mind. With the context of HIV in South Carolina disproportionately affects Black people. It's also 3 to 4 times higher for American Indians, Alaska Natives, and Native Hawaiians, or the Pacific Islanders compared to non-Hispanic whites, and 1 to 2 times higher for Hispanics compared to non-Hispanic whites. It is also higher among gay and bisexual men, who represents almost 50% of all 2019 primary and secondary syphilis cases transmission. This pattern holds across most of the other reportable sexually transmitted diseases. The gonorrhea rates is almost 42 times that of heterosexual men in some areas when you dig down into the data nationally. But it's not just the men that are affected. Our adolescents and young adults are also impacted. So those age 15 to 24, what our 2019 data shows is they represent 61% of chlamydia cases and 42% of gonorrhea cases. And the growing incidence of STDs is not new among people living with HIV/AIDS. And when you combine that with our annual transmission rates through mostly sexual transmission, you kind of understand why this is an important issue to pay attention to. And then if you start to overlay the COVID effects, then you will see that we do have a lot of work cut out for us in the future. And just to provide you a concept, historically, where you have high cluster incidences of syphilis, it's always a precursor of increased HIV transmission or incidence of HIV. So before we got here, before we had COVID, we already had contributors to increased incidence of STDs, and that's just based on our public health infrastructure. So we were not doing as much screening, we had cut costs, budget, staff, we did not have enough in treatment, partner services, all of those issues were all adding to the increase in the transmission of STDs. Now, this is only worsened because of COVID or during COVID, because we've, in response to the epidemic, had to move resources out and people had to work from home and remotely and all of those things. So now we even have more reduced services and staffing, and that is going to impact what happens in the future related to the rates of STD transmissions as we've seen them since they continue to occur. So we have an under-resourced workforce dedicated to this, which means that we have reduced access, even from a screening perspective, to be able to monitor and help engage people who are affected in the relevant care. Now, why is this significant? So HIV is one of those disease conditions that sexual transmission plays an important and significant role. And it does that because of 2 reasons. One, we're working towards ending the HIV epidemic. And to end that epidemic, there's several pieces that have to happen. One of that is we need to reduce transmission. And the way to reduce transmission is to get people into effective care and all of those things. When we start to see people living with HIV get higher incidences of sexually transmitted diseases, then we worry about the fact that they're being exposed to risky sexual behaviors, which can expose them to different strains of the virus. They can transmit to uninfected people. They can transmit different strains between partners who are already HIV positive. And so there's importance here that we need to pay attention to. Again, providing the context around that, in South Carolina, we have a rate that is almost the sixth highest in the United States. We have over 20,000 people living with HIV in the state. Nationally, 5 to 10% of those who are in HIV medical care are actively infected with either gonorrhea or chlamydia at any period. And so we have this understanding that, and this are those who are even accessing healthcare regularly have this challenge, and we also have those who are not in HIV medical care yet. So when we look at those, what the data shows us is if we look at those who are aware of their HIV status, but not in care, they are contributing 42.6% of STD transmissions within that group, compared to those who are in HIV medical care will contribute only 20%. So we have a problem on our hands with people living with HIV regarding STD transmissions. So again, like I said, that impacts our new infections, impacts our drug resistant strains moving back and forth across different populations. From a care linkage perspective, it's also a missed opportunity to link people back into HIV medical care. And if we leave this untreated, there's significant issues beyond just the transmission. You got physiological issues, you got impact on pregnancies, and depending on the type of STDs, the impact could even go beyond and affect other body organs. So our aims in this study were, one, to create a de-identified database for HIV, STDs, and other linkable healthcare services that could give us an indication of some of the patterns and important predictors for who's likely to be infected with STDs among people living with HIV in South Carolina. Then we wanted to look at examining and describing positivity rates among different groups of people living with HIV in South Carolina to see how often do they get infected, what do they get infected with, are there repeat infections and important predictors or like those. And then we wanted to look at that and then say, can we then use machine learning algorithms to predict those clusters of patients most at risk for getting infected or reinfected with STDs going forward. So we wanted to leverage our strength in South Carolina using our health data warehouse, where we can link by name individually. We do not do the linkage. The linkage is done by our honest broker, which is the South Carolina Office of Revenue and Fiscal Affairs. And we use that using the population database, where the population of everyone living with HIV is collected and reported in the DHEC electronic HIV/AIDS reporting system, which can then be combined with another mandatorily reported system, which is the STD and MIS databases with DHEC at the individual level. So we can get information on reportable sexually transmitted diseases like chlamydia, gonorrhea, syphilis, and hepatitis, and then use that as our population database. And then combine into other data sources, we can use machine learning techniques to flag and identify those clusters of people living with HIV in South Carolina at risk for STD or an STD reinfection. Hopefully this clustering or cluster information, which is more specific, can help guide how we target interventions to these people to help them to screen and to provide the assistance that they need. So our data sources are going to come from multiple places. I could talk about the HIV/AIDS reporting system, ER's electronic system. We're going to use the STD-MIS system from DHEC, and then unique data structures and other linkages from the Office of Revenue and Fiscal Affairs. We're going to manage those data together once we get the data from the RFA, because they are the ones that act as honest data broker. They're able to de-identify and give us unique identifiers such that we can longitudinally track and follow each individual patient, person living with HIV in terms of what has happened to them related to STDs. We'll take all of those data sets, the combined pieces, clean it, make sure that we understand all of the variables that are there, verify that variables are correct and interpretable. And we expect a flat file. So we have repeated measures coming across because you're going to have people across different years going back to 2005 to 2020, looking at what's happening within this population group across the STD spectrum. So for our methods, we're going to do a combination of supervised and unsupervised learning, letting the data inform us, but we also already have some outcomes in mind, so it's not a complete black box strategy. But our supervised learning will help us cluster different groups based on their patterns of STD positivity among the people living with HIV. We'll be able to cluster them or find nearest neighbors and see who looks alike, who is behaving in the same patterns, what they are, what are their traits, what are their characteristics. We're also going to use transition dynamic analysis, and our goal here is to model time to next positive STD tests, and then dimension reductions using standard dimension reduction methods like PCAs, random forest, partial least squares, linear discriminant analysis. And then for our supervised learning, since we know what our outcome is, we can then use best combinations of these methods, whether we're doing multinomial regression or cost proportional Hodgson model. This just gives you an idea of what the predictive analysis based table looks like. So again, from the time of first diagnosis, we can go forward and kind of monitor to see when you test positive for an STD, how often you test positive for an STD. We can categorize your variables as either time fixed or time varying variables, right? So we can look at what happens as a function of times and its relationship to that, and it'll help us with our clustering analysis. So we're still working on this. Our future plans got hit a little bit because Yale don't like them right now. Still one of the students that were started working on our project. We can't hold the student back. We understand. I mean, it's Yale. You can't say no to them. So we're hiring for data students in case you have those who have those interests in big data science. We're working on our approvals and updates because we, again, want to make sure we have the most recent data, particularly now that we will have an effect because of COVID. And we're looking at working throughout the summer to complete the analysis in our work and get the information out. These are references, and like we stated, we'll take questions after everyone else presents. Thank you.
Dr. Hughes, would you like to start your presentation? You're still muted.
That might be better. Remind me how we do the share again.
Oh, sorry. So I can see your screen, but now all you need to do is hit the presentation mode.
Okay.
And then at the top of your PowerPoint screen, display settings, swap. There we go. Perfect.
Great. Well, thank you. So we had a lot of fun with our project. In fact, we're still in the process of analyzing data. Anytime you get data from other sources, you probably spend the majority of your life cleaning the data so that you can actually use it. We took a slightly different approach than what was previously discussed and looked at some of the work that we had been doing on medication safety and also readmissions, and tried to build upon that to take it to the next step. In looking at hospital readmissions, anyone who is admitted to a hospital for either a medical procedure or a surgical procedure has the risk of being readmitted. And for some patients, that risk ends up being basically zero, whereas other patients, such as those with heart failure, can be as high as a 39% chance of readmission. When CMS introduced a penalty for certain readmission conditions, what ended up happening was there was a nationwide push for how we could reduce readmissions. There's been various efforts happening throughout the country, focusing on the top 10 conditions that CMS is looking at. And the rules were set in place for 30-day readmissions. The penalties were put in place in a phased-in approach. And so what that ends up being is a penalty for the whole cost of that care associated with that readmission. In many respects, it's been argued that the penalty hasn't been high enough, and that while readmissions have decreased during the introduction of this penalty program, they could be reduced even further. Problem is how we approach reducing readmissions, and the majority of that responsibility has been put onto readmissions, on hospitals, so that they can prevent that revolving door of readmissions. When we looked at the literature, there are several barriers to reducing hospital readmissions. And if you look at this list, the majority of these factors aren't in a traditional electronic health record within a hospital, nor are they within any one data source. I would argue that they're not even within an insurance company's information. So what we did is we looked at how could we combine some of these different databases that are in different sources with an EHR and holding our left-hand side of the equation to readmissions. And we continue to work on this in that, again, readmissions are predominantly predicted based on what's occurring within the hospitalization, not what's happening before and after, or nor the continuum of care. We understand, based on other research, is that we need to look at readmissions within the continuum of care. But to do this, it requires linking databases that have not been traditionally linked. And then also you get into the whole issue of what is the unit of analysis. For example, a lot of the public use databases are available at the county level, but not necessarily the zip code. And for example, we know within South Carolina that there are several zip codes that do have high readmission rates, but ironically, even though the hospitals know those zip codes, they haven't integrated that into their readmission risk scores. So for our study, we looked at 4 specific aims to basically build a composite measure that could be used for future research. Looking at things such as medications, because we know that that is significant for hospitalized patients. We also wanted to look at whether or not patients were accessing or taking those medications, taking advantage of a variable that we introduced into the AHR through another study, and then combining it with large data sets, including characteristics of the community as well as characteristics of the population. So looking at some census data as well as health resources within communities, again, at the zip code level. And then we wanted to combine all of that together to see if we would end up with a better predictive score for readmissions. So our first model looked at medications and basically took a composite measure with the over 100,000 cases that we had over a 2-year period to see if there was each of the medication factors weighed into predicting readmissions, such as the number of medications, if they were on a high-risk medication, how complex the medication regimen was, and that includes whether it was oral or IV medications, and then how many medications were changed during the hospital stay. So that was our first model. Our second model was taking advantage of the question that we embedded into the EHR, and that was where nurses would ask patients upon admission if they had any problem getting or taking their medications, and it was a yes/no answer. So we added that to the model. The third is where we took advantage of zip codes that the patient was being discharged to, combining the community characteristics such as how many pharmacies, grocery stores, and then also looking at the patient characteristics, including whether or not the patient lived alone and then also SES of the communities themselves. Then the fourth approach was using common models that are used within hospitals now that physicians use as part of their decision process to determine whether or not a patient is ready to be discharged. And the first is the LACE score, and the second that's being more commonly used is the hospital score, which also includes lab values. So in adding those in, we looked at how could we improve our predictive modeling with the area under the ROC curve. And what we found is that by basically adding all of these different factors together, we were actually closer to predicting one. So our model's predictive ability improved significantly. But one of our concerns is that while we're adding these variables, that we might be actually forcing the results. And so we're in the process right now of taking this and seeing if we eliminate certain variables, if we can get to a smaller model than what we have now. And in many respects, this parallels what we're doing in terms of bundling services. So what healthcare providers are doing in many health systems is they're bundling what works into one package, but that ends up creating quite a list of factors that they're looking at, but they're not stepping back and saying, are there particular factors from each of the bundled instruments that could be pulled together to look at readmissions instead of all of the factors. And one of the things that we're finding that's pretty consistent are individuals living alone, individuals that have had previous history of not taking their medications. And then of course, as in parallel to what's been found in previous research, is looking at whether or not they've had certain conditions such as heart failure. Heart failure is one of the most problematic conditions for patients in readmissions. And then also in terms of patients being able to manage their condition while they're home. And then the last factor is really looking at those community resources. We're starting to see a trend, and we're hoping that as we add to our database and include information for more hospitals across the state, that we'll be able to really see the impact of community factors, such as examples, how many primary care providers are within a community, as well as how many pharmacies are within a community. So we're very excited about our findings, but we really want to continue increasing our samples so that we can test our model even more so. So our next steps is that we are taking this concept and submitting an RO3 next month. And then we are also looking at a display interactive dashboard that providers can use that actually links community variables with what's going on in the inpatient setting to better predict readmission. And it gives the providers the opportunities to make changes. So for example, one of the factors that for some conditions keeps patients home past the 30 days is whether or not the patient was discharged with home care. For other conditions, if a patient is referred home with home care, it actually increases their chance of being readmitted. And so what we can do with our historical analysis now as we're moving into using artificial intelligence is whether or not a patient can, or if a provider can decrease the chance of readmission by sending the patient home with home care based on the patient's diagnosis and letting the provider visualize that risk score in real time. So we're very excited about this, and we're very happy to engage with any questions that you may have. Thank you.
All right, let me share my screen here. So hopefully everyone can see it.
Looks good.
All right, excellent. So just want to tell you a little bit about our project and where we were focusing on racial and geographic disparities in the utilization, adherence, and economic cost of targeted therapies for breast cancer. So just to kind of give you a brief overview, I'm going to talk about the significance and rationale, the research question and specific aims, a little bit about our methodology, the research team, progress that we've made, some of the preliminary results, lessons learned, and then where we want to go for a future look. So I feel like this graph really gives the heart of the matter of what we're getting at. If you look at cancer rates for African Americans, particularly for breast cancer, you see that incidence-wise, actually, European American women are more likely to have more likely to get breast cancer than are African American cancer. But then when we think about mortality, that flips, and African Americans are more likely to die from their breast cancer, whereas European Americans are less likely. And because of that juxtaposition, so to speak, between incidence and mortality, really the mortality is that much worse because mortality statistics that we commonly use don't take into account who gets the cancer. So we like to use the mortality to incidence ratio where that takes that into account. And this is what we have done previously in some of our work where we use the mortality to incidence ratio to compare what does that look like, what does mortality look like for white women in South Carolina, what does it look like for Black women in South Carolina. And we have, I'm not going to go into a lot of detail with that, but we color code it so that lighter colors are a better outcome, darker colors are a worse outcome. And as you can see, African Americans here on the right-hand side have very much an increased burden of breast cancer mortality. So, you know, this really highlights we've got to figure out what's going on here and begin to make some changes so that we can intervene upon this statistic. So the other thing that this project takes advantage of is the fact that over the last decade, there has been an explosion of targeted therapies in cancer that have come on the market. And people are really excited about these because they have the opportunity to really, for certain subsets of cancer survivors, to really get to the heart of their cancer and are actually have better treatment outcomes than with traditional approaches of radiation therapy or chemotherapy. So this kind of just depicts how if we find a molecular target in one group, they can get that therapy. And a lot of times they don't even have to have other types of therapies, and this can put their cancer in remission. And so but then there are also groups that aren't affected, don't have a particular molecular marker, so they may not be eligible for, or it may not be a good candidate for the targeted therapies. So we are wanting to look more closely and ask the question, could lack of access to and utilization of breast cancer targeted therapies contribute to breast cancer disparities experienced by African American women? And so our aims were such that we were going to describe and compare the utilization, first off, of the targeted therapies by race, by geography, and socioeconomic status. Then we wanted to look at adherence to targeted therapies, also by race, geography, and SES. And then finally, we also wanted to look at the economic cost. Once again, by race, geography, and SES. So with our methodology, we are going to utilize a retrospective cohort design that incorporates, a linkage between the South Carolina Central Cancer Registry, and that's where we're going to get our cancer cases, with treatment information from the State Employee Health Plan or Medicaid. And in such a way, the Cancer Registry has really good information on cancer diagnosis and its staging and all those things, but the information is less reliable when it gets to treatment, and it's very limited. You just get what they call first course of treatment, and there's usually a whole lot more that happens that's just not captured in those databases. So with the administrative data from the State Employee Health Plan or Medicaid, we can then get, because it's all about reimbursement, right? So we get really good data on treatments that they received and procedures that they received. So by putting those two together, we can really harness a great resource. And we had begun to do this with work, and that's what I love about this, is that it's growing and growing, and hopefully will continue to grow. Because we had already started this breast cancer cohort using by a R15 mechanism that I had gotten back several years ago. And so we had begun the cohort then, and we started with cases in 2000, and at the time we went through 2013. But interestingly, with targeted therapies, those have not come on the market till really a lot, mostly after 2013. So we really we're not able to look at those with the current data that we have. So we're proposing to basically expand that cohort, collect all the same treatment information, but now we're going to start with our 2013 cases and go up to cancer registries about 2 years lag. So we'll go to 2019. So we are interested in, based upon our specific aims, the independent variables are going to be race, urban and rural status, as well as socioeconomic status. Our outcome variables are going to be treatment utilization as a yes, no, days from diagnosis to administration of the targeted therapy. We're looking at adherence. So are they 80%, and the benchmark is 80% adherent to guidelines for administration, and patient out-of-pocket costs also for targeted therapies. And then we also want to understand survival as well, and what are targeted therapies and access to targeted therapies going to play on the survival outcomes, which is ultimately what we want to change. So I want to give a shout out to my research team. This is a group of amazing scientists that are very productive and very collegial. So Dr. Crouch is our economist. Dr. Swann is our geographer. Dr. Felder is our social work scientist, but as well as a community expert, African American community expert. Dr. Hastings comes from pharmaceutical outcomes in pharmacy, and Dr. Wickersham is our clinician nurse scientist on the team. So we have, this is where COVID has impacted us, because we have not gotten data as quickly and easily as we have in the past. So we've submitted luckily we've gotten all approvals for our data from DHEC, and which I thought maybe DHEC might be even more delayed with approvals. But now with the data set, getting that in our hands is where we're seeing some delays and other priorities with the pandemic, as would be expected. But in the meantime, what's nice is we've got our current cohort that we can use to begin to develop our coding algorithms for targeted therapies. And so we've done that utilizing both a literature review approach as well as team expert validation. We have also are creating the algorithms for all of our summary variables, of course, for the data, because we'll get not millions, but we'll get thousands of records per person. So we've got to collapse those down into one summary variable for many of our outcomes. And then I'm also very proud of the fact that we have submitted 2 grants from this proposal. One has been awarded already from the Oncology Nursing Foundation, and that was to expand this work into looking at targeted therapies in lung, colon, and prostate. And then we just submitted another R01 application in March that is looking to expand the cohort just in terms of all treatment outcomes for lung, colon, and prostate as well. And cervical is the 4th one that we're adding to that. And I know we don't necessarily have results that we can share at this point in those applications, but what is really nice and how we're selling it is that this is institutional support for these ideas, as well as leveraging of resources, financial, as well as knowledge and personnel to really set these applications up for success. So I think that will play well, or has played well. So preliminarily, I just wanted to show you what we have in the current cohort. I don't know that too much is relevant here, so I'm not going to spend too much time, but we've got about 28% African American. So we will have a good number and we expect these proportions to be similar once we have the extended data set. We have 16% rural residents as well, which will give us some further diversity and all stages of disease too. So what I find most interesting, we have published previously on one form of targeted therapies, although it's been around for a while. It's been hormonal therapies. And these are not kind of the new age ones. This is kind of an old hat one. But it was really interesting in our previous work that we read analysis primarily on people who had evidence of at least one prescription for our treatment. And so that kind of limited us. They had to at least started before we could assess their adherence. Well, then we began to look at, well, what about all people who should have been eligible for this? And what did those proportions look like? And we were amazed that when we began to account for that, how our adherence, which was originally on the higher side, like at 91%, dropped to 84% adherence when we started taking into account all women who were hormone receptor positive, who should have begun this therapy. And we began to see differences when we broke this out by race, with African-American women having less adherence, by urban rural status, where interestingly, this went in kind of the opposite direction of what you would expect, and that there was higher adherence among rural populations. And then we begin to put race and rurality together, and once again, we see that there are still significant differences in that in both groups, African-American women, whether they live in rural areas or urban areas, had lower adherence. So we are interested in further exploring this in these newer therapies to see, does this hold true, and what that looks like for their survival. So where we want to go, where we've begun to go, the creation of additional cancer cohorts. I love big data because it just keeps growing and keeps giving, I say, in some ways. So, and I love about it that we can utilize it to do some data mining with faculty, postdocs, and students. So I love having collaborators. And so anybody that's interested in utilizing the previous data, the new data that we get, we love collaborators. In my heart of hearts, and I feel like this is kind of the prime group for getting this message out, is we need to link Medicare to this. This is a huge gap that we have. The cancer registries act somewhat independently, except for the SEER Cancer Registry that has just 5 states in it. The big national cancer registry that has 5 states in it has linked to Medicare, and that's been done. But the individual states have not begun to link their individual data at the state level to Medicare. And I feel like, we can't, and so we can do that, we can't get a good picture of what's going on in the 65+ group. So I keep advocating and looking for avenues, how can we broker this? And there's just a lot of reluctancy on the national, from CMS, as well as from our state DHEC to, who's gonna give up ownership of their data to allow the linkage. So we're also, I think the obvious endpoint to this too are the provider and patient interventions to overcome barriers to utilization of targeted therapies. And there's also room for advocacy, policy advocacy and intervention, because, with insurance, it's all about, can you get this paid for? It is a large determining factor of whether or not you're going to take therapies. We all are subject to that, right? So, and that happens a lot of times at a policy level, particularly our state health plan as well as Medicaid. So those I see as where I would love for my collaborators to take stuff. I don't know that I'm the best qualified to take those forward. And just my contact info, and for those of you, so I'm a child of the 80s and also grew up a bit in the 90s. So there's a song called Baby Got Back, and it's, my really good friend, Dr. Felder, sent this to me because it's a line from, or somewhat line from one of their songs, that I like big data and I cannot lie. So that's it for me. Thank you very much.
Well, thank you. Thank all the presenters for wonderful presentations. So we are very happy to support those wonderful projects. Also happy to see the progress you all made, especially with your grant submissions. Amazingly, some of the expansion of the current project already got funded by other foundations. So that's really, we want to see, that's the role we want to play. So Dr. Adams has a very nice summary during the presentation. We really want to show by our minimum support, we have the infrastructure, we have the network here to support your work. So now I think we open for questions.
Yeah, if anyone has a question, you can use the raise hand icon and I can allow you to speak, or you can type your question into the chat box.
I would like to make one comment because I need to give a shout out to one of my team members. So Dr. Karen Wickersham is the PI for the Oncology Nursing Foundation grant that was funded, and I'm a co-investigator on that. So I didn't want to take credit for that one because that was her a lot of times, but you know, this provided important resources. So.
So you don't see any
No,
hands up?
Not seeing anything yet.
Okay. Oh, we have a question. Oh, well, comments. Yeah, I agree. Yeah.
I would like to ask a question, if I could, of Dr. Hughes. I'm really intrigued by your dashboard idea and wondered if you could share a little bit more about that, because I think, you know, are there ways eventually as things move forward, you know, ways that that can disseminate into other areas like we see with cancer, that type of thing?
Well, I think that's one of the things that we're really excited about, because it's a way to really link the research as well as clinical practice together. And so it basically is built on, so right now we're at 4,000 variables in our model because we had to take each medication and make it a 1 and so on and so forth. Then by linking that with real-time EHR data, you can actually make differences in patient outcomes. So we can say, based on what's happened in the past, this patient is likely to be readmitted. If you do these things, you can actually decrease the readmission. But the only way we've really been able to enable that is we literally have linked 58 databases and created over 4,000 variables. Based on, at least right now, 2 years of retrospective data. So it's not something a hospital could do by themselves. They really do need links to these other, not only databases, but the previous analytic work that's been done. So there's a lot of possibilities with it. So we're very excited.
In thinking about that, and you know, going back to my big push for linkage with Medicare, and you know, how do you bring those stakeholders to the table and get them to, you know, in order to link, somebody's got to give up, you know, personal identifiers in some way, shape, or form for the most part. And how do you broker that? How do you get organizations to do that?
So what we've been doing with the sensitive data is that we provide code that de-identifies the individual and brings it down to the zip code level. And so essentially what it would do is then link it with a de-identified patient identifier for the hospital. So we as researchers or anybody outside of the hospital would only have that de-identified number. And so that's been the easiest way. But yes, we just go ahead and write the code for them in SQL Server, so that way they have the master list. That's worked so far.
We have one hand up from Dr. Hikmet, so I'm going to allow him to speak now.
For Dr. Adams, this is Nashed, and I work with Ronda, but also work with many other faculty. One way, we have a project with Dr. Brooks John Brooks, and he works on orthopedic studies. So my team handles the identified data that comes from Prisma Health. I'm the honest broker per se. So Prisma Health pushes the data to us based on the business protocol that they have developed. We receive the data, we keep it on a HIPAA compliant secure server. Based on your needs, you tell me which elements which you want, we bring them down, we match it, we identify, encrypt it, and then put it on your server for your use. So there's many ways, but Ronda knows this, but it took about a year and a half to 2 years to get them agreed on every aspects of this process. But at the end of the day, we have developed that university has accepted the process, so it's a part of it. Coggins, is signed up on it. Susan at that time, now she's left, I believe, the HIPAA compliance officer at that time signed off on it, and Prisma Health themselves signed off on it. So it took a lot of painstaking back and forth, but there is we have developed the process, either as Ronda said, you submit the code to them and they'll pull it based on that, or we get monthly data pushed to the secure server, compliance server from Prisma Health. Then my team de-identifies that based on your IRB request, and then push it down to your server for analytics purposes. So there's a lot of, I think we have developed enough expertise that if we need it, and that's the Big Data Health Sciences Center, we do the same thing. And as a health IT core, I believe, for the Big Data Health Sciences Center, that's part of my role and my team's role. We did the similar process, securing the data on the server on this side too, internally. So if you need help, that's what BDHSC is for. We can work and then
Yeah,
prescribe 2 Tylenol and call us in the morning.
I would love to begin some conversations. We've used, the DHEC agrees to use RFA as for their cancer registry data as the honest broker in that, but RFA doesn't have access to Medicare that they can link on. And so, Medicare at the national level says they have to, they want the data, they have to be given the data from the registry before they'll link, and they'll perform the linkage themselves. They're happy to do that, but then DHEC says, no, we're not going to release that data. And it's just, that's where we get into trouble, that I'm just trying to figure out ways that I can lessons learned from other groups, and ways to, and bringing and leveraging and certainly, Dr. Hickman, I'm going to follow up with you because ways that the center can help me put pressure on as much as possible to break, because I'm happy to do it any way, shape, or form we can do it. I just want de-identified data with Medicare in there. So.
I think Dr. Lee's main mission when he put the Excellence Center was to be able to facilitate that in reality, and as such request comes in, I think we can take those to our, Doc Foster is on our side to help any which way from university side, but also Banky has established quite a strong relationship, like yourselves, with the both DHAC and RFA, and probably this kind of ongoing relationship is trust building, I believe, about our abilities. Everybody's going crazy as if we're gonna take the data and then put it on Facebook or Twitter it around. So that's the exercise we're going through, and hopefully we'll build that confidence and the relationship with state organizations. Because I believe we can. I remember a few years back with Dr. Brooks's. There is a protocol that you can sign with Medicare, but they would give you the identifiable data based on certain, there was the reason was, I think he said, if we need it, that we have to follow up with the patient. Can we, so there's some way to link that, but probably we have to do more study research how to get that in place. But I think the grant application that Dr. Lee had with the COVID-19 repository, those are in works, I'd say. They can talk more about it, Banky and Dr. Lee. I'll shut up now.
We do have one more question, and I think that's about all the time we have, from Desi Wu for Dr. Hughes. She asks, how do you manage your stakeholders to make your project happen?
Well, while Dr. Adams focuses on Tylenol, I'm looking at hard liquor shots to manage, but a lot of it really does depend on the relationships you build with the owners of the data. And so the approach that we have taken is multifaceted. One is we take advantage of that service element for our workload, and we provide basically free research, free input to our stakeholders and give them feedback. And so that's one of the things that they have really capitalized on. The other is we don't necessarily just take the data and run. We take it, we develop a list of mutual questions and then provide feedback to the holders of the data. And so it's a constant process. And then one thing I say in a joking way is that I assign over my firstborn if in any way I misuse the data. Of course, the caveat is I don't have a firstborn, but it really is a constant process to establish trust with those stakeholders. But if you can find, in many respects, you have to find mutual territory. So as a researcher, why do I need your data? And then what are you going to get out of giving me your data? And so I try to build that into basically meeting the operational needs of the organizations. And so that has really opened up incredible opportunities. And right now I'm in negotiations with 2 other health systems in particular. So I'll get my N from about 118,000 up to 300,000, hopefully within the next couple of months. But it's basically, it's those relationships. They make me happy, I make them happy.
I think we're ready to close. Thank you guys so much again for such fantastic presentations. It's always fascinating to hear the work that the pilot project recipients are doing, and we're excited to have a new batch of recipients pretty soon. So thank you attendees also for spending another hour with us. We look forward to in-person seminars next semester. Have a great rest of your week.
Thank you all.